IUI is a very good option for unexplained infertility. Usually, we would recommend about 3 cycles of IUI in unexplained infertility and then proceed with IVF. Some couples may choose to go directly to IVF, and that would depend on the age of the couple, the goals of treatment, how many children they want to have, obviously the financial aspect as well. But certainly, it is considered first-line treatment for unexplained infertility.
Another great use of IUI is when couples may have a mild male factor infertility. So what does that mean?
Hi, superhumans. I'm Dr. Mavis Garcia.
And I'm Dr. Wise.
We're 2 of the physician leaders at Markham Fertility Center, otherwise known as our baby, MFC.
As fertility specialists, we've witnessed firsthand the challenges, triumphs, and the myriad of emotions that come with trying to conceive. Whether you're just starting to think about having a baby, actively trying, or facing challenges along the way, My Fertility Podcast will be your go-to resource for honest conversations and a supportive community.
So grab a cup of coffee or tea and settle in, and let's demystify the world of fertility together. Welcome back. Today we're going to talk about IUI, or intrauterine insemination. This procedure involves placing the sperm inside the cavity of the uterus at the time of ovulation, and it's very commonly used in the fertility world.
Mm-hmm. When I was doing some research for this episode, I found a study that was published with Ontario data by Dr. Maria Velez in Kingston at Queen's.
Shout out to Dr. Velez.
And shout out to Queen's, my med school alma mater. But so basically between 2006 and 2021 in Ontario, there were 1.7 million pregnancies that were included in this big retrospective review. And 96% came from unassisted conception. But what's really interesting is that 1.7% of pregnancies came by IVF and 1.4% of pregnancies came from IUI. And so the actual number of pregnancies coming from IVF and IUI is about the same, it looks like, in Ontario over this time period. So that was interesting.
Yeah, IUI definitely has a role in the fertility world, and it's a bit downplayed sometimes because we know the pregnancy rates are lower, and we're going to get into the details of why that is. But it's certainly a great option for many people looking to conceive. It is also less expensive and less invasive compared to IVF.
One of the really challenging things when you're counseling, or at least for me, when I'm counseling patients about fertility and fertility treatments, is that really in the world of fertility treatments, we have ovulation induction and cycle monitoring, let's say for intercourse. We've got IUI and IVF. And so there's not really that many treatment options that we can necessarily offer. And we can kind of boil things down to these 3 options. The pregnancy rates with IUI and IVF, and the difference between IUI and IVF can feel huge. Like it can feel like there's this great big divide between these 2 things sometimes. But that doesn't mean that IUI isn't any good or that it isn't successful. As we said, there's lots of pregnancies that are coming from IUI. And so it's really important to consider it and to figure out whether this could be right for you.
So who is it right for? Who is IUI ideal for? Well, one of the situations in which IUI is ideal is in unexplained infertility. Unexplained infertility is a condition where a couple has been trying to conceive for at least a year, and there is no specific cause of the infertility. So the fallopian tubes are open, the sperm is normal, there is no ovulatory dysfunction, and there is no anatomical abnormalities with the uterus that would be preventing implantation. IUI is a very good option for unexplained infertility. Usually, we would recommend about 3 cycles of IUI in unexplained infertility and then proceed with IVF. Some couples may choose to go directly to IVF, and that would depend on the age of the couple, the goals of treatment, how many children they want to have, obviously the financial aspect as well. But certainly, it is considered first-line treatment for unexplained infertility.
Another great use of IUI is when couples may have a mild male factor infertility. So what does that mean? When we have a couple and they come to a fertility clinic, one of the tests that we do a lot is a semen analysis. And sometimes one of the sperm parameters might be a little bit low or a little bit suboptimal. So either a little bit of a lower sperm count or a little bit of a decreased motility. When that is relatively mild, IUI can oftentimes enhance the ability of the sperm to get to the egg and actually fertilize the egg by getting the sperm a lot closer to where it needs to go at the right time, and then also getting more sperm past the geographic distance, if you will, of the vagina, the cervix, the length of the uterus. IUI can help us get more sperm closer to where they need to go. And so that can really help assist, if you will, or give the sperm a bit of a head start is often what I say when it comes to fertilizing eggs. So for couples where there is mild male factor, IUI can be a great option.
If you want to know more about male factor, refer back to episode 7, where we talked about male factor infertility, lifestyle factors, and supplements that men can use to improve their sperm. Another great option for using IUI is for people who require the use of donor sperm. Who may need a donor sperm? It could be a person who wants to be a single mother by choice. It could be a same-sex female couple that need donor sperm to establish a family, or it could be a heterosexual couple that has male factor infertility and wants to use donor sperm insemination as a way to build their family.
Another time where we might discuss IUI or think about doing IUI is for a couple, let's say where the assigned female at birth partner has an ovulatory disorder, like PCOS, for instance, or polycystic ovarian syndrome, which we've talked about previously on episode 16. We may start with trying some timed intercourse and ovulation induction, but again, it doesn't necessarily always work. And so oftentimes we may add on or move into IUI because now that couple's diagnosis or their journey has progressed or has changed a little bit, where we have this ovulation disorder potentially, but then maybe there's an element of unexplained infertility as well once we've overcome those ovulations. Sometimes for couples who have failed timed intercourse cycles, we may move into IUI.
IUI can also be very useful in couples that have what we call coital factor infertility. So that means the inability to have penetrative intercourse. This could be due to a variety of reasons. For example, due to vulvodynia or pelvic floor dysfunction or vaginismus. It can also be due to issues with timing because, let's say, the male partner is traveling a lot, so you might want to freeze sperm and use an insemination at the time of ovulation if the male partner is going to be away for an extended period of time. It can also be due to male ejaculatory disorders like erectile dysfunction. And I would add as well that sometimes when people who are trying to conceive, the pressure of having to time intercourse can get to be a lot. So it's not uncommon for couples to experience coital issues during the time they're trying to conceive. So IUI can be a bit of a relief because it does allow the sperm to enter into the uterus at the time of ovulation without the pressure of having to perform.
All right, so let's get into the nuts and bolts of this IUI procedure and an IUI cycle. When we're thinking about an IUI, there's basically 4 main points. We're going to go through the growth, preparation of the egg and the lining, culminating in this insemination, and of course the after stuff and waiting for that pregnancy test. First, we're going to talk about that cycle monitoring aspect. We can talk about preparing of the sperm, the insemination, of course, and that post-IUI time period. Okay, what is this cycle monitoring? What are we looking for?
So in the cycle monitoring, we want to see that there is at least 1 follicle. Sometimes you can have 2 or 3, and that is important because if you have more than 1, we need to counsel you about the risk of multiples. We want to see that there is at least 1 follicle growing. We want to see what the size of the follicle is. Sometimes we're looking for a natural ovulation, which should be an increase in the LH surge. Sometimes we don't see that. But if the follicle is the right size, we can give you a medication to induce that release of the egg. And we're also looking at the endometrial lining as well. During the cycle monitoring, either ovulation can happen completely naturally without any medications at all, in which case we just monitor to see the development of the egg and the onset of the natural ovulation, or we can give you medications to induce ovulation. And then again, the cycle monitoring is to monitor that ovulation and determine when would be the perfect time to perform the IUI procedure.
So now you've got a good follicle, our lining looks good, we've figured out the timing for this insemination. So what happens next? The next big thing is that we want to get a semen sample. This could be a matter of thawing, let's say donor sperm, or thawing sperm from the partner, or it could be getting a fresh sample. Now, we often will always say fresh is best. So in a situation where we have the option of getting a fresh sperm sample, let's say from the partner who is going to be the sperm provider, then our preference would be fresh sperm, having the partner produce the sperm sample via masturbation on the day of the insemination. But of course, we will very often work with frozen sperm, and the pregnancy rates can be excellent.
So once we have the fresh sample, we have to do what is called the sperm wash. And the sperm wash is a crucial part of the IUI procedure, because unlike intercourse, during intercourse, the semen is deposited in the vagina. And then the sperm from the semen has to travel through the cervix into the uterus, into the fallopian tube. In an IUI procedure, we're depositing the sperm directly inside the uterus, very close to where it is in the fallopian tube. So we don't want to be putting in things inside the uterus that are not meant to be there. We just want the sperm to be going in and know all the proteins and fluid that is present in the semen. So in order to isolate this, we want to concentrate what is called getting the most motile sperm. So the sperm wash, it's the way to accomplish this.
Once we've got the wash sperm, the next thing is the actual procedure, the actual insemination. The way that it works, we will have the partner who is going to be the carrier of the pregnancy. So during the insemination procedure, we'll have the partner come in, we have them take their bottoms off, you're lying on an exam table, and to be honest, it really looks and kind of feels like a pap smear, getting a pap test. So the legs are in the stirrups, a speculum is inserted into the vagina so that we're able to visualize the cervix. The cervix kind of looks like a donut with a really small hole center. And so basically we're seeing this at the back of the vagina, and then we use a very thin, flexible, soft catheter where we draw up this prepared sperm sample and we put the catheter in through the cervix into the top of the uterus. Now, it's very important to point out that an IUI or insemination does not feel like a sono, even though in both of these things, we're putting a catheter in through the cervix into the uterus. When we're doing an insemination, the volume of fluid that we're using is significantly lower. And so that's why most women don't even feel the insemination, or they may just have some mild cramping. So once we navigate through the cervix, we deposit the sperm at the top of the uterus using our little plunger on our syringe. And really, it can take 5 minutes to do the whole procedure from start to finish. It really is most comparable to getting a pap smear or a pap test. I always highlight to my patients that it is not like the sono at all.
Yeah, it's generally a painless procedure. Sometimes it can take a little longer because we do want to make sure the catheter goes through the cervix into the uterus. And sometimes the angle of the cervix can be a little tricky, which is why we ask you to have a full bladder for the IUI, because it does make the angle between the cervix and the uterus straight, making the insertion of the catheter a lot faster and a lot more comfortable for you. And speaking of full bladder, right after the IUI, you can get off the table and go on into your bladder. Many people like to lie down for about 5 minutes and have a moment of quiet and peace, and that's perfectly fine. You're welcome to do that here at Markham Fertility Center. It's not necessary, and if you're really uncomfortable and you need to pee, or if you have somewhere to be, you are well to get off immediately from the table, go on into your bladder, and carry on with your daily activities.
Mm-hmm. After the insemination, what happens then? All right. Really, there is no magical thing that you should do or magical things that you shouldn't do. Really, you assume that you're pregnant until proven otherwise, meaning that, you want to avoid things like alcohol and smoking, and you want to continue on your prenatal vitamins, but generally go back to your normal activities.
Just to clarify, when we talk about regular activities after IUI, that would include things like exercise, cycling, walking, working, having sex, swimming. Like really, we mean regular activities. The things that would be restricted are things that would be restricted in pregnancy, and that would be like hot tubs, saunas, jacuzzis, hot yoga, any contact sports that can put you at risk of injury. But you can carry on the same day of the IUI and do what you would normally do otherwise, with, of course, all the precautions that women who are trying to conceive in generally will have.
Usually a pregnancy test will be booked about 2 weeks after the IUI procedure. The other point is that we will often prescribe progesterone or additional progesterone medications after the IUI procedure up to the pregnancy test, and then continue on the progesterone if your pregnancy test is positive. Honestly, your body is already making progesterone after an IUI because you have ovulated, either because of a natural LH surge or because you were given a trigger medication. So your body is already producing progesterone. We do like to give additional progesterone to help support that early pregnancy as well. And so that's typically done by suppositories. I've had some patients who don't really like suppositories and end up doing progesterone injections, which is equally fine as well.
Why don't you tell us, Dr. Wise, why is sperm wash so essential for an IUI procedure?
Yeah, absolutely. So sperm washing really does serve a purpose. To be honest, I don't really love the term sperm washing. Like, it makes it seem like it's dirty and therefore we have to wash wash it in some way, which I don't know, that one doesn't sit quite right with me. I prefer to think of it as sperm processing, that we process the sperm sample so that it is usable in an IUI situation, but whatever, that's just my own beef,
No,
if you
I
will.
think you're right. I think language is very powerful. And just like we say people with ovaries versus women, the way that we express ourselves says a lot about the hidden meaning. So I think you're right. I vote that you are right and that we should change the term from sperm washing to sperm processing.
I also realize that this is not the first time that I'm ranting on this podcast about my disdain for certain names of things. I don't know, maybe this is going to be a theme. Like, who knows? I finally get to get out all of those rants that have been in my mind for all of these years. What can I say? I love podcasting. Anywho, so sperm washing, sperm processing, however you want to think about it, is really important. In fact, it's truly essential in an IUI procedure. What does it do? Number one, for sure, it enhances sperm quality because the process of washing the sperm helps to concentrate that motile sperm, brings them together, and it really increases the average speed of the sperm because you're getting rid of all the slow swimmers, all the dead sperm, etc. And so you're really enhancing the chances of fertilization there. As well, going through this wash, you're reducing all the contaminants. So all the other stuff that is in semen, like seminal plasma, dead sperm, white blood cells, as you alluded to earlier, you're really significantly reducing the risk of introducing contaminants that could cause infection, which obviously is really bad and would negatively affect pregnancy, or inflammation in the uterus. So for instance, if you took a semen sample and you put it directly into the uterus, all of those prostaglandins that are there in semen would cause severe cramping. And so we can't do that, right? And that's why the sperm wash is so important. The sperm wash also facilitates something called capacitation. This is the final maturation step that's required for the sperm to fertilize the egg. And so when we wash it, we actually help facilitate this process. You're getting better quality sperm that are more likely to fertilize as well as they go through the sperm washing process.
So let's talk about timing of IUI. We recorded another episode about when to time intercourse for maximizing conception, and that's episode number 4. But the timing of IUI may be a little bit different than what we talked about in that episode because in an IUI cycle, we're actually doing cycle monitoring and we know exactly when the ovulation is happening. And we know that you're ovulating when we see that there is an LH spike, which we would see when we're doing the blood work. Or if there is no LH spike and we're giving you the epidural, that is the trigger of ovulation. So we would time the IUI according to that.
Generally, IUIs will fall around day 13, 14, 15-ish in the cycle. It can vary depending on whether you're on medications or not.
Yeah, the important thing is that we time it based on what we see on cycle monitoring, not on what day of the cycle you're on.
That brings up a really good point, actually. This is a commonly asked question. So why is it that sometimes, Dr. Garcia, you trigger an IUI and sometimes you don't?
It really depends.
I'm putting you on the spot here.
You're putting me on the spot. It's okay. I love you too, Dr. Mike. So it really depends on whether or not there is an LH surge happening. So if we see that the follicle size is, let's say, 2.0, the lining is gray, and the LH is, let's say, 30, and the day before it was 12, that is a very clear LH spike. And then there is no need for the epidural because you have naturally ovulated. Important to realize that, at least at Market Fertility Center, this is specific to our clinic, we don't know the results of the blood work until around 11:30 or lunchtime. When you come in the morning and you meet with your nurses, the nurses only have the information about the size of the follicle. So let's say 9 a.m. in the morning, you come, you do your blood work, then you do your ultrasound, you see the nurses says, oh, you've got a follicle that is 2.0, you might likely need a trigger today. But then the blood work comes back around 11:30, 12, and I'm reviewing it, and I see that the LH has gone up really nicely. We call that a surge, and then you might not need a trigger at that point. Having said that, if you still want to do a trigger, even though there is an LH spike, there's absolutely no problem to this. And I know a lot of physicians still do a trigger even when they see an LH spike.
Yeah, absolutely. The other thing with the trigger is that sometimes it can actually be really handy to use a trigger. It might actually be more convenient. What I mean by that is that sometimes we may push the follicles to surge. So we might wait and see or wait until the follicles will start that surge process on their own before we set LH jump happening naturally. But that means more appointments for you as the patient. So more times coming in the early morning for bloods and ultrasound. And so sometimes patients might prefer actually to use a trigger medication, even though you're taking another medication, even though it's an injection medication, but it can actually save you from visits. That's another consideration that we talk about when we're thinking about planning an IUI cycle.
I'm going to put you on the spot now. What's the trigger, Dr. White? See, it goes both ways.
Awesome. Okay, so a trigger basically is a medication that is used to trigger the follicles. Basically, it causes that final maturation step to happen for the follicle so that that follicle is getting ready to pop open and release that beautiful, gorgeous egg to be picked up by the fallopian tube. I mean, okay, maybe I don't love the word trigger. Again, it has different connotations.
There we go, people.
But it is true. You're setting off this course of events, right? That you're sort of mimicking that ovulation. You're giving this hormone via the trigger medication that mimics this big LH surge, this big LH jump that happens, that sets off this course of events for that follicle to pop open and let that egg come into the tube.
So IUIs can be done through a natural cycle. They can be done through ovulation induction. And ovulation induction can either be oral medications or it can be injectable medications like gonadotropins. How do you choose between oral medications and injectable medications?
It's a really good question. And it definitely varies from fertility physician to fertility physician in terms of their philosophy on this. We see it a lot when people are coming to us for second opinions or when people are coming to us from other fertility clinics. Personally, I will always consider trying the oral medications first without jumping into injectables right away, unless there's some really specific reason, right? But I think that taking a pill once a day for 5 days is way easier than having to do daily injections. And in fact, there's been research to show that in an IUI cycle, let's say you have 2 follicles, right, that we see on an ultrasound. Whether they come from injectables or whether they come from oral medications, the pregnancy rates are the same. So if I can get the same effect from somebody just taking an oral medication for those 5 days as opposed to needing to go into injectables, which, again, way higher cost, you have to give yourself an injection every day. There's way more monitoring involved. So there's more appointments, blood work, and ultrasound to see what's going on. And a higher risk that you're going to end up being canceled because there's too many follicles, because those injection medications are much stronger, then, I mean, for me, I will always try those oral medications first. Now, does that mean that I never use injectables? No. I will definitely move into injectable medications depending on that patient's history, depending on the circumstances. But I think it's always worthwhile to try the oral meds first to see if we can get a good effect so we don't need to jump into the injectables.
There are 2 oral medications that we use during an IUI cycle. One is letrozole and the other one is clomiphene citrate, with letrozole being more commonly used and more popular. We actually go into details about these 2 types of medication on PCOS Part 2 episode, so I would recommend that you listen to that to learn more about letrozole and clomiphene citrate for ovulation induction. We talked about the ideal candidates for IUI, but let's talk about which patients IUI it's not for. That would be, for example, people that have blocked tubes. Now, if you have only one fallopian tube, you could still do IUI as long as that remaining fallopian tube is open. But if you have no fallopian tubes, or if both tubes are blocked, or if both tubes have hydrosalpinx, then IUI, it's really not a good treatment for you, because during an IUI, the egg and the sperm need to meet in the fallopian tube and travel all the way to the uterus. Speaking of fallopian tubes, another condition that could happen with IUI is an ectopic pregnancy, where the egg and the sperm meet in the tube and then the embryo implants in the fallopian tube or somewhere else outside of the uterus. IUI in itself doesn't increase the risk of ectopic pregnancy above the risk associated with ectopic pregnancy in a spontaneous conception, but because fertilization is taking place in the fallopian tube, then there is an increased risk of ectopic pregnancy with IUI over the risk of ectopic pregnancy with IVF. But this risk is not increased over natural conception. So for patients that have had 2 or 3 ectopic pregnancies, even if they have fallopian tubes that are open on sonohistogram, it might be advisable to have a discussion about IVF so that you're bypassing the fallopian tubes altogether.
Another reason why we may kind of dissuade patients from thinking about IUI is where there is severe male factor. What does that mean? To actually have a successful IUI, you have to reach a certain number of sperm after the wash to get the best or the maximal pregnancy rates. And so sometimes when you're starting with a lower number or a really decreased percentage of motile sperm, after the wash, you may be left with very, very few sperm. We know that if there's just less sperm that we can use post-wash, we know that the pregnancy rates are going to be much lower as well.
In situations like this, then it might be better to use IVF, and particularly ICSI, where you take one sperm and inject it directly inside the egg. And I would refer you to episode 14, where we discuss this in more detail. Now, another situation where IUI might be less successful would be in women of advanced reproductive age. This would be age 38, 39, 40, or over. This doesn't mean that you cannot do IUI if you're older. It just means that there is a lower pregnancy rate, and also the time that you're spending in IUI, it's precious time that if it's not successful, then it makes the IVF that you might do in the future less likely to be successful, because the chances of IVF are highly correlated with the age of the egg that is being used. There is something else I want to say. I have heard on social media, or patients sometimes tell me, oh, I was told that because I have a low AMH, I have to do IVF and I cannot do IUI. Or I was told that because I have endometriosis, I have to do IVF and I cannot do IUI. And I would say that having a low AMH or having endometriosis is not a reason for why you have to do IVF and you're not a candidate for IUI. All that means is these are factors that can interfere with the chances of natural conception or the chances of conception with IUI. Generally speaking, we know that the pregnancy rate with IVF is higher than the pregnancy rate with IUI when you compare cycle to cycle. And that's why in these situations where there is endometriosis or advanced maternal age or a low MH level, IVF is more recommended than IUI, but it does not mean that IUI cannot work in these situations. And we know that AMH, it's not a marker of fertility and it's not a predictor of live birth. All it tells us is the number of eggs that you're going to get during a stimulation cycle.
I'd also say that patients who want to conceive multiple children, it's important to talk about whether IUI is an appropriate option for them at that point. What I mean is that we know that if, let's say, a woman is older, 36, 37, 38, etc., doing IVF first to be able to bank multiple embryos because she still wants to have several children may be a really good idea. What I mean by that is that if you do IUI, let's say at 38, and you get pregnant, great, awesome. That's wonderful that you're pregnant. If it's very important for you to have another child after that, well, if you do IUI, 9 months of pregnancy, 6 months to recover for your period to come back, you're going to be closer to 40 by the time you're now trying for that next pregnancy. It's going to be that much more difficult. And so I think that that's another important part of this discussion in terms of whether IUI is a good option or not a good option for somebody. Now, maybe somebody will want to do IVF, bank embryos specifically for future use, and then come back to IUI. I mean, that's a totally reasonable choice as well. But it's part of that bigger family planning discussion. And really, I think as with everything and pretty much anything in the world of fertility, it's really all a matter of having that discussion with your care provider and understanding the risks, the benefits, the odds of success, etc.
Now, let's talk about the cost associated with IUI. We know that it's much less than the cost associated with IVF, but there is still significant cost with it. So in Ontario, the Ontario Fertility Program covers IUI cycles. There is no age limit, which is different from IVF, which has an age limit of 43. So for an IUI in Ontario, there is no age limit. There is also no limit in the number of cycles of IUI with the Ontario funded program. It does not cover the medications used for an IUI, whether they are gonadotropins or oral agents. And it also does not cover the cost of the sperm wash, which, as we talked about, the sperm wash is absolutely necessary for doing an IUI. It's important to know that not all clinics have Ontario-funded program and unfunded IUI cycles. So when you're working with a fertility clinic, it's important to understand this because even though it doesn't cover everything, it covers quite a bit. Mm-hmm. So working with a clinic that has funded IUI program available can really decrease the out-of-pocket cost for IUI.
And of course, it's important to note for our listeners that MFC, we do have funded IUI cycles. And we have a large number of funded IUI cycles, so we don't run out at the end of the fiscal year. Because again, I hear about that happening at some fertility clinics as well. Let's say you're doing IUIs and it's getting to be towards the end of the fiscal year. So your clinic may simply run out of IUI funding and you may end up having to pay for the whole thing out of pocket. And again, the costs for that vary widely. I've heard $1,500 to $2,500 for a non-funded IUI.
And with the funded IUI, you're only paying for the sperm wash, which could be anywhere between $700 to $800, depending on which clinic you go to. And of course, the cost of the medication, which if you're using an oral medication like letrozole, that cost is minimal. It's less than $100 for a cycle. So now, just to make this more fun, we're going to answer some commonly asked questions about IUI.
To be honest, I'm actually really excited to hear how you counsel patients, because we never get to listen in on each other's conversations and how we talk to
fun
patients.
is we can do a clinic together so we can listen to each other.
That'd be my dream. No, if you have any good lines or any good ways of explaining things, I'm totally stealing them.
I don't want to let you listen.
That's flattery, right? What did they say? Imitation is the sincerest form of flattery.
Okay, you can flatter me all day.
We've talked a lot about IUI, the process and how it happens, but does it work? What are the success rates, right? This is probably the biggest question that's going to help patients determine whether this is a good option for them. So how do you counsel patients around the success rates for IUI?
So the success rate for IUI depends very heavily on the age of the egg producer. For women who are under 35 years of age, the pregnancy rate per single IUI cycle is between 10 and 20%. Then it's between 10 and 15% for women over 35 years of age. And after 40 years of age, the pregnancy rate is about 5 to 10% per cycle. I want to emphasize the term per cycle because the cumulative pregnancy rate over multiple cycles could be higher than that. For women who are under 35 years of age, doing up to 6 IUIs, the cumulative pregnancy rate could be anywhere between 45 to 55%. Now, no medical procedure is without risk. The risks of IUI are really minimal, but they exist. What are some of the risks that you talked about with your patients about IUI?
IUI is generally really safe, but as with anything, as you mentioned, there are some risks or really some considerations, I think. One of the big ones, of course, is multiple pregnancies. So we're talking about twins, triplets. But again, when we're doing cycle monitoring or we're doing blood work and we're doing ultrasound, we get a very good idea in terms of how many follicles there are, how many eggs there may potentially be. And so there's a risk that we may actually cancel your cycle if there's too many follicles that are being produced and that we feel that the risk of multiples is too high. Now, that being said, if you're maybe a little bit older, we may be deciding to use the medications, the injectables or the oral meds to get a couple of follicles to increase the pregnancy rates. We are kind of walking this fine line between trying to get, let's say, multiple follicles growing so that we can increase your odds of a pregnancy, but keeping, in mind that risk of multiple pregnancy is there. Hey, I got a fun fact for you.
Shoot.
Do you remember John and Kate +8? That show on TLC?
Yes, I remember. I'm still traumatized by it.
Well, so a lot of people think that John and 8 plus,
Plus
the
8,
8,
yeah.
because they had twins and then they had 6 tuplets, right?
Yes.
Yeah.
Yes.
Okay. So the 6 tuplets came from an IUI pregnancy.
Yes.
It was not an IVF pregnancy. So this does relate back to this podcast episode. But yeah, what happened was that I believe she was on these injectable medications for IUI. She had a bunch of follicles growing, and it was supposed to be an IUI cycle. I don't know the details exactly after that, but again, the risk of multiples is actually higher in IUI than it is in IVF, because in IVF, you actually have some control over how many embryos are going to the uterus. With IUI, there's a lot less control.
I was going to say, to get 6 doublets through IVF, you would have to transfer at least 5 embryos together.
Yeah.
Minimum. Maybe 4 if you think about 2 of them splitting, which would be pretty rare.
Exactly.
So yeah, no, that makes sense that it would have been an IUI.
We'll look it up later. There are other risks with IUI as well. When you're on these fertility medications, you may experience some symptoms of mild ovarian hyperstimulation. What that means is that you may feel some bloating, you might feel some discomfort, you may feel like your tummy just feels really full, some constipation. But generally, these symptoms are pretty mild and manageable. It would be extremely rare that you would have such significant ovarian hyperstimulation syndromes that you would require hospitalization. It would have to be a very, very bizarre set of circumstances. The risks are relatively low, and whether it's risk of multiple pregnancy or hyperstimulation, these can be managed with proper monitoring and the ability to cancel a cycle. In a case where there's too many follicles growing or things are just not going well, we may cancel the cycle and advise contraception for that particular month. From the actual insemination procedure itself, there is a risk of infection because, again, we're introducing something from the outside world into the uterus. But the risk of infection is very, very low. And then the procedure itself can cause some mild cramping. You may have some spotting as well.
What is a good number of sperm for an IUI?
Great question. This one comes up a lot. Let's say on the day of the IUI, here at MFC, we get a printout, a report on the sperm. So we have a general semen analysis that gets done in the sperm sample that day. You get the count, you get the percentage motility. Then the lab goes through the wash procedure, and then you get a other report about what the sperm looks like post-wash. These numbers are going to vary widely, right? Pre-wash versus post-wash. So remember, with the wash, you're taking out all the slow-moving sperm, all the dead sperm that aren't swimming well. And so you're going to end up with a way lower number post-wash. That's expected. That's totally normal. It's also important to note that the number of sperm, the total motile count, that is the total number of swimming sperm in that post-wash sample, can vary clinic to clinic and depending on how they're performing the sperm wash procedure. I know, for instance, here at MFC, we review the data internally on a regular basis. And so we can graph where we're getting the optimal pregnancy rates, where we're getting the best pregnancy rates, what our count should be post-wash. And that's the number that I always reference to patients when we're talking about the sheet and when we're reviewing it. The total motile count that you get here with an IUI may vary, may be different from what it was at a different clinic, but those pregnancy rates are going to be the same based on each clinic's internal data and sort of what their predicted pregnancy rates are going to be post-wash.
So what is the number here, MFC, that you tell patients?
I usually will counsel patients that we want at least 2.5 million post-wash, ideally over 3. That's where we're seeing the best pregnancy rates. Another really common question that comes up, of course, is about sex, right? And about intercourse.
But what about sex after IUI? What do you tell patients?
So in a situation where the sperm count was good, where we got a good optimal number of sperm, I say sex now doesn't help, doesn't hinder, and that it's really up to, if you feel like having intercourse, that's totally fine. If you don't, that's okay. But again, that's in situations where we got a really good number of sperm post-wash at the time of the IUI. Sometimes when the numbers are lower and we know that it's below that optimal number, having intercourse just kind of gets more sperm there at the right time. So it's going to improve things a bit. All right, here is the big question for you. How do you counsel patients when they come to you and say, why didn't my IUI work?
It's a good question, and you feel like it should have worked, right? You got the timing perfectly. We know that you're ovulating. We know your fallopian tubes are open. You got the sperm count. Sometimes I see people with having done 3 IUIs, and the sperm count was amazing every time. The lining was perfect. We put it in the right place at the right time. Like, it really should have worked. And the answer to your question is we don't know. And at the end of the day, when we're doing an IUI, we are checking the boxes on a lot of external circumstances, but we don't actually know what is happening inside the fallopian tubes. What is the quality of the eggs? We cannot see that in an IUI cycle. What is the egg and sperm interaction? We cannot see that. Is the embryo developing properly and traveling into the uterus? We cannot see that. Is there an issue of implantation, like the talk between the endometrium and the embryo? We cannot see that in an IUI cycle. So all that we see is that we have the pieces there, and then we see whether or not the pregnancy happened or not based on the pregnancy test, but we cannot see the in-between of what happened. And that's why the pregnancy rates with IUI are not as high as you would like it to be. And that's why when IUI doesn't work over 3 to 5 cycles, we suggest IVF, because with IVF, we're able to increase the odds because we're taking more eggs, but also we're able to see the egg and sperm interaction, genetically test an embryo, and aid with implantation. If you want to know more about IVF, you should check out episode 14 on the podcast. I hope that you found this episode useful. Yes, we know that IUI has a lower pregnancy rate than IVF, but it does not mean that it doesn't have a very important role in your journey to start a family.
Really, though, I think it's all about having that discussion with your fertility physician about bigger goals and about what your expectations are, because more than anything, going into something like IUI or IVF, really being on board and understanding what the expectations are is so important so that you can proceed knowing all the facts. And that's a wrap for today, Superhumans.
If you're looking to connect, get social with us. Follow us on YouTube and Instagram at My Fertility Podcast or visit us online at markandfertility.com. And don't forget, follow, subscribe, and share your favorite episodes.
Thanks for listening to My Fertility Podcast and for being a vital part of our community. We know you've got this.
We're signing off until next Tuesday.
If you found this episode of My Fertility Podcast helpful, please take a moment to head over to the review section and leave us your thoughts. Your reviews and comments are incredibly valuable to us and help guide future episodes. We also welcome you to direct your questions to info@myfertilitypodcast.com.
My Fertility Podcast is produced by Rabbit Media Inc. in conjunction with Dr. Garcia and Dr. Weiss. Music from Mix Kit Raising Me Higher by Ajay Stelino. My Fertility Podcast is not intended to replace any type or variation thereof professional medical, health, or legal advice, nor should the content be taken as medical advice. Please contact your primary healthcare professional regarding any medical questions you may have. The information presented in this podcast is based on the knowledge and understanding of the host at the time of recording. Medical knowledge is constantly evolving, and new research may change the understanding of health-related topics. While we strive to provide accurate and up-to-date information, we do not guarantee the completeness, accuracy, or timeliness of the content. The views expressed in this podcast by guests are not those of the host or the management. This podcast is not intended to impose any type of discrimination. My Fertility Podcast and its management are not responsible for any losses, damages, or liabilities that may arise from the use of this podcast.